with covidinstitute.org, and I treat long COVID, POTS, chronic fatigue syndrome, and MCAS. And I'm going to go ahead and bring on Amira. And here she is. Let me fix this.
Hi, good morning.
And good morning. And I want to reiterate that nothing we say here is considered personal medical advice for treatments. If you want that, you're welcome to schedule a private where we can talk about specific or personal treatment plans. Hi, Mira. How are you?
Good morning. I'm doing okay. How are you all doing?
I'm great. It's a rainy morning. I wanted to talk a little bit about May-Thurner syndrome. It's been brought up a few times, and I'm going to go ahead and share a screen here. And particular picture is from the Cleveland Clinic. And what I wanted to show was that basically the compression occurs right around the L5 vertebrae on the front of the spine. And it's a compression of um, the artery compressing the vein. And it's right at the junction between the iliac artery and iliac vein. And this condition is actually more common than we realize. It just happens to be diagnosed more frequently now because of COVID and long COVID. So the majority of people in up to 20% of our population has this condition. And this is a normal variant in anatomy that allows for this. And a lot of people don't have any symptoms at all. It is during COVID and long COVID where the inflammation and I guess the inflammatory reactions that occur that exacerbate the condition and let it present itself and is diagnosed. If you didn't have COVID or long COVID, you may go your entire life and never know you've had this. So this is not at the hip, though. A lot of people are saying that it's at the hip, and it's not really at the iliac crest either, but it's at the level of the iliac crest. It may be slightly caudal or closer towards the legs compared to the iliac crest. But really, this is not a hip or an inguinal problem. This is a problem of basically the great vessels, where the iliac vein is at the junction of the vena cava is getting compressed by the arterial counterpart against the bone. And the bone here would be the vertebral body of your spine. So I hope that makes sense. But when there's compression of the vein, there's decreased or eliminated blood flow, which would mean that that particular leg would swell because the blood would not drain properly. And because it's not moving, the blood is not moving, it also increases risks of clots, which is why we see not only clots, but emboli to the lungs, for instance, because that's kind of the area that tends to go to. But we are ready for questions. If anybody has any, let me see here. Hi, Dizzy Lulu. So if anybody has any questions about long COVID, about MCAS, about POTS, about chronic fatigue syndrome, these are all related, or about any of the causes that I believe are kind of involved. So we have a question about from a Facebook user asking, what is unique? Let's see, how do you do a very unique HGB, and may only a doctor that does it in this way? how is it different from a traditional C4, C6 stellate ganglion block for PTSD? Dr. Mulvaney and Dr. Lynch found that, well, in reality, it really wasn't Dr. Mulvaney or Dr. Lynch that founded this procedure. This procedure actually goes back to the late 1800s. Granted that the addition of C4 or C3 to block the superior cervical plexus was adding these. Actually, what's his name? I'm blanking on his name now. It'll come to me in a second. There's a doctor in Chicago that kind of pioneered, I think, that Dr. Lipoff pioneered adding in the C4. But I believe he also worked together with Dr. Mulvaney to develop this for PTSD. So it's not just the level of where it's placed that makes what I do unique. It's the location and where I put the medications. It's not just in one spot. A lot of docs, what they'll do is they'll stick a needle in, and we'll do a little test with like half or 1 milliliter, and then we'll put their entire contents of the local anesthetic into that one spot. I place it into several different spots depending on what I'm seeing on the ultrasound image. So if I'm happy with the way things are spreading, I may not have to move the needle, but often I do. So that's kind of the main difference, where I put it as opposed to what I put in and at what level. Let's see what we have. Heidi is, hold on, before we go to Heidi, we have another Facebook user asking about vitamin D. I talk about vitamin D. Yes, that's fine, Amira. That's perfectly fine. Go for it. But you have to unmute yourself.
Good morning, everyone. I'm Amira Saleh with the Long COVID Association. If you're just joining us now, Dr. Groysman is an expert in long COVID. He's dual board certified in anesthesia and pain management and has a clinic in Irving, Texas. COVIDinstitute.org is his website. We'll start out with this question here. I'm going to go ahead and
It's the
pull up
vitamin
my
D
screen.
question.
I think you have control over how they move across the screen. I could do the one at the very top. Okay, here we go. A question further to your talk about vitamin D last time. Did you say it's possible to have high vitamin D levels in the blood, yet be deficient at it if there's a problem with the gut, liver, or kidney? How do we detect that if it's the case? How do we know?
High vitamin D in the blood.
Is it possible to have high vitamin D levels like with that gentleman who passed away? They said from excessive values like 384, some very high level.
Well, I believe the cause of death for him would have been the hypercalcemia rather than the vitamin D. One of the main consequences of having high vitamin D levels that are activated. Okay, so just having vitamin D in your system does not mean that it is active. There are two steps that need to happen to turn it from biologically inactive, which is the same stuff, by the way, that we produce in our skin and from plants and from animals. So, but it still needs to go through two different enzymatic reactions in order to activate and become biologically active. So the first activation just makes it slightly active. It still sort of works well, but and that happens in the liver, and this enzymatic reaction happens in the kidney. And um, once that happens, then your kidneys and your gut start retaining calcium. They also retain phosphorus. But there are consequences, obviously, with having too high calcium levels, more than just strong bones. um, so I'm not sure if I understand the question exactly. Um, can
I
you help me with this, Amir?
I'm I'm wondering, um, that was the first ever case of vitamin D that high. Usually, if you're on any supplement, you're working with Dr. Groysman, he regularly checks your values, because as your health improves, you may not need as much supplement, and vice versa. If you're under a flare, you might need a little more of particular vitamin, depending on how your organs are working together and how your gut microbiome status is. So, um, and how your gut tissue health is. Dr. Groisman taught us before about um, how you can become you can suffer from two major things in the gut: malnutrition and malabsorption, and that affects everything else in your body, from your hair to your skin, nails, every organ. So if you're not getting enough, you'll see it in your neurological symptom, neurological system, excuse me, and you'll see it um, across the board everywhere. That's why, like, nutrition is a foundational piece to any treatment plan you get in recovering from this condition. So it's kind of like you have to pay a lot of attention to both what you're feeding your gut tissue and your gut microbiome. Dr. Groisman told us how important fiber and foods that contain natural fiber in it, fruits, vegetables, these things are like really important. And when you're not feeling good, you may not have the energy to go and, um, make yourself a salad. At some points, I've had to go and blend it into a smoothie, put all the key vegetables together into a smoothie, and oh, it's vegetable soup now. So, uh, you do what it takes to feed yourself and work towards healing yourself. But as far as knowing about excessive high vitamin D, I basically know about that from my mother, who had chronic kidney disease. She was one of those folks that put everybody ahead of herself, and she didn't use blood pressure medication when she got older like she should have, and she developed, chronic kidney disease. She was at, the earliest stages of it. But there was another concomitant condition, secondary hyperparathyroidism. Is it hyperparathyroidism or hypopara? I think it was
Hyper, yes.
hyper. Yeah. And uh, that meant she had to really be careful of how much intake of calcium she was getting in her diet from, like, cruciferous vegetables and beans, as well as still get her vitamin D in her diet, because that's like a cornerstone immune system supporting vitamin. I mean, it really makes a huge difference in people. Um, anyway, so uh, I know that watching these things, these vitamins in your, the only measurement we really have easily is our blood test. Um, and urine tests that we generally can get access to. But to find out, how much you're absorbing, your doctor, like Dr. Groisman, he'll look at other things as well to see if you are actually getting the benefit of the vitamin D, and you might need a combination. Everybody needs some sunlight, right? For the other like melatonin and
Well, sunlight is
to
important for
overall
vitamin D
wellness.
generation,
Yeah.
but we're talking about a blue-white light being exposed directly to the eye. That doesn't mean that you have to stare at the sun. Please don't do that. And that does not mean that you have to turn on a bright lamp, white, blue frequency or wavelength, I should say, and stare right at it. It could be your eyes and the light source. So that means things like glasses, windows can interfere with that absorption. And that, if done before 10 a.m., whatever your time zone is, will help set for the next 12 hours your circadian rhythm with release of melatonin roughly 12 hours after that 15 to 30-minute exposure. But if we're talking about skin exposure, that's where vitamin D gets made. And again, it's still inactive, even if it's made in your own body, and it still needs to go through the liver and the kidney to be isolated and activated. So let's talk about vitamins in general, okay? Can potentially accumulate in your body if you overdo it on supplementation. So the big ones are the fat-soluble vitamins, which is A, D, E, and K. Okay, there is such a thing as getting too much vitamin A, and there is such a thing as getting too much vitamin D. That story, while horrible, it really is very rare. That are fat soluble in your system. Okay, such as kidney disease. You know, whether it's chronic chronic kidney failure or even acute kidney failure, that could potentially result in decreased elimination of vitamins. Okay, and they can accumulate. One other one that's a little strange, but is true and it's been documented, is vitamin B6. And while it is water soluble, it can potentially accumulate in nerves. And normally it stays in muscle, but in certain conditions, like with dehydration, for instance, it can the B6 can translocate to nerves, and that can actually cause a neuropathy. And if enough of it accumulates, it may be a lasting neuropathy. This is, like I said, not a common thing, but there's been documented cases of it. So having high D vitamin levels in your blood may or may not be an issue because one is it activated? Because if it's not activated, it's not really doing anything except being attached to albumin and a few of the other blood proteins and just circulating around, but it's not really doing anything. Vitamin D is very important in calcium absorption, both at the gut and the kidney level. And parathyroid hormone, then, you know, since Amira did mention it, is really mostly responsible for calcium absorption, as far as regulating calcium levels in the blood. Okay, your body wants to keep calcium levels within a very narrow range in the blood because there's certain effects that happen if it's too low, if it's too high. let's go and take a look at some other questions.
Here's one
Please.
from, oh, I thought I was going to get to read it.
Go ahead. Go
Okay. Oh,
ahead.
okay. Heidi asks, hi, can you tell us more about detoxing the spike protein from the body?
Sure. So let's talk about spike. Spike protein, spike detox, and microclots are kind of the big thing in the news, or at least they were. They seem to creep up every couple of weeks. So where are these spike proteins? Well, one place is vaccines. That's what the vaccines are designed to do, the COVID vaccines. Both the mRNA and the Novavax vaccine are really introducing spike protein into your body. And the idea there is that you form antibodies to the spike protein, and therefore it confirms immunity. However, as we know, it doesn't really prevent you from getting COVID, acute COVID. That's been demonstrated very aptly at the CDC convention, where the majority of the members were actually everybody there was vaccinated, and from introduction of COVID by likely one person, everybody got it, or the majority of them got it. It may prevent hospitalization, but it doesn't prevent you from getting COVID. So what are these spike proteins doing? Are they circulating around in your bloodstream? Are they sitting in the area that's infected? These spike proteins are attracted to ACE2 receptors because that's what they're meant to bind. That's the way they're designed. When they attach to an ACE2 receptor, they will be internalized into a cell. That could be a white blood cell, or that could be a liver cell, or be an endothelial cell in your gut or in your lungs. Once it's internalized, it also takes the ACE2 receptor with it. So the idea is how are you detoxing from it? If most of the spike protein that's in your body is being intracellularly. I mean, that's a question I'm asking because I answer for it. So how do you get rid of it? How do you detox from it? Let me fix the question, by the way. If the majority of these proteins are internalized, now whether they're internalized inside blood vessels, in the endothelial tissue and cause damage that way, or they get internalized into white blood cells and cause issues with cells that way. So I have, it's also a question for me. How are you really detoxing from it? I know there are several medications that have shown, or supplements that have shown to detox in a test tube or a petri dish, in the sense that they destroy a spike protein. Now, items like nattokinase or streptokinase or lumbrokinase. I know ivermectin has been mentioned to do this, NNAC. At least for the kinases, they're not really kinases, but they are proteases, and they break apart protein. And spike is still a protein, and it's able to break it up. But is it truly detoxing a person? I couldn't answer that.
Rachel's with us.
Yes.
Long
I
COVID advocate.
can't put her question up, though, because she's not on the main chat line.
Okay.
But you're welcome to read it.
Okay. Rachel, are you able to talk on this, or are you just connected via text? Okay. All right. Well, I'll read her question. Rachel asks, I would like to know if the COVID virus the same as HIV.
Sure. So, I mean, the best way I can answer this is I don't know. But what I can, HIV is a retrovirus. HIV attacks one particular cell type in the immune system and inserts its genetic material into our genome, which makes it persistent. There hasn't been definitive evidence that the SARS-CoV-2 does this yet. However, there have been findings that there are remnants of viral material of the SARS-CoV-2, one of the viral materials, in our system that could imply that there is some persistence somewhere, or that virus is being produced somewhere. Or it can also be that just the viral remnants are being produced and they can cause similar symptoms to long COVID or long COVID. So in a way, there's dysregulation of the immune system, but I wouldn't liken COVID-19 to HIV. And one of the main supporting points that I want to mention is the antivirals. So one of the ways that HIV and AIDS is managed is by continually taking antivirals to suppress viral replication. And that has not really been successful in COVID. Even if you're continually taking antivirals, it does not prevent or relieve the symptoms of long COVID for the majority of people. Have there been reports of people recovering or getting better with antivirals? Sure, but it's not the majority, which leads me to think that this is probably not the same resistance type that happens with HIV. I hope that answers your question, Rachel.
I would also mention that the HIV virus, its target is, mainly human beings. This particular one, human beings, and it has specific affinity for the T cell. Whereas in SARS-CoV-2, it can infect multiple species, which is something unusual. Different species. It can infect certain bacterial cells that are in our gut. Don't know if it's going to other bacterial cells in our other microbiome areas, like in the lungs or on our skin, other areas. But I've seen studies where it's actually infecting the bacteria in the gut, and that study was Dr. Carlo Brugna in Italy. There's a few papers on that, which really can add to some of the persistence and how we're sort of measuring how endemic SARS-CoV-2 is through our wastewater. They're very different that way, and also SARS-CoV-2 can infect just about everywhere in our body. It can infect our over 61 different tissues, blood cells, immune cells. So it has both are devastating viruses to get. But the fact that it can go and target anywhere in the body makes it harder to tackle it. It's like you have to have a system-wide, comprehensive approach, multi-levels, to treat this virus and attack it from all different ways. Anyway, those were some of my thoughts about the differences between them. You know, one is anyway, next question, right?
Well, one is an infection and a real infection, and there's viral replication, and the other there's viral components that are found, but active viral replication has not been proven, at least to my satisfaction.
Okay.
So that's another difference. Wherever it's happening, if it's if it's happening in the microbiome or it's happening in different cells, you should be able to extract live virus and show that it's replicating. But anyway, let's move on to MCAS.
Okay.
If you'd like to read the question.
Okay. All right. Do you have labs you order to confirm MCAS? I guess they're wondering lab tests.
Yes, I do. Lab tests are not required for diagnosis of MCAS. MCAS is a clinical diagnosis. It's diagnosed based on symptoms and the timeline and various aspects of why we think it could be MCAS as opposed to something like histamine intolerance. When additional histamine, or you're not metabolizing histamine, or you're not eliminating histamine. Our gut plays into this. Histamine is made by some species of our microbiome, but the two tests that may be helpful would be more of urine tests and 24-hour tests. And the reason is because if you do a spot check, like a blood histamine level, you may miss a spike in histamine or an increase in histamine or a flare. And if you're checking for tryptase, tryptase is really mainly looking for anaphylactic flare rather than MCAS. And remember, mast cells contain a lot more than histamine. They contain many different enzyme inflammatory factors that can contribute to MCAS but don't contribute to, let's say, a histamine intolerance. But if you're going to check with labs, and again, these are not definitive tests. If you test positive, you have, and if you test negative, you don't have MCAS. That's not how it works. But you can check N-methylhistamine in the urine. I prefer a 24-hour test. Metabolite, one of the metabolites, histamine. You can also check for PGI-D2. Both of these should be chilled to avoid. And you really need to be off non-steroidal steroidals like corticosteroids, and you need to be off for some medication that are not technically antihistamines but have an antihistamine component. Can also alter the results. So those are the tests that I would check if I was not completely sure. Again, it's not really a confirmation. It's more of a, does it support the condition? But it shouldn't change the diagnosis based just on the labs.
Rachel had a follow-up question about, does the virus affect our joints? Does SARS-CoV-2 affect our joints? And it's kind of fitting after you talking about MCAS. If you could explain to us how that's happening. How
Sure.
does the virus affect our joints?
Post-viral arthralgias and myalgias, COVID, but to many different viruses, even some cold viruses um, can do this. Flu can do this, and it's inflammation inside the joint, whether it's direct um, involvement of the virus inside the joint causing the inflammation, or if it's an autoimmune component because you've did autoantibodies to something that mimics synovial or joint, something in the joint that gets inflamed, typically self-limited to a few weeks, and it's necessarily the virus infecting your joint. There's other, including the inflammatory response. That's kind of all I have to say
Here's
about
the
that.
next one from. Okay, thank you, Dr. Groysman. Ashanti asks,
Ashanti.
yes, are there any new answers on muscle wasting, which is resembling ALS, but no testing lines up? There's a large number of us in the group suffering from muscle atrophy with no answers. I
You're
haven't, I
breaking up,
think,
Amira, a bit.
okay. I can repeat it. Is there any new news about muscle wasting that resembles ALS? But no testing lines up. There's a large number of folks in the group suffering from muscle atrophy with no answers. So they're wondering, why are their muscles shrinking? Can you hear me
So
now?
there's yes, I can hear you. Um, there's there's several different possibilities. Um, the simplest explanation is when that happens, your muscles atrophy. However, in long COVID, I believe that it's mitochondrial. There's a mitochondrial. This has been proven with muscle biopsies, showing that the mitochondria are not functioning well, and muscles are fairly oxygen or oxidative um, metabolism, or metabolism dependent. So if you take away the function of mitochondria, which are the main energy supply for muscles, they would tend to atrophy. So I wouldn't be looking at it from the ALS point, because ALS is more of a neurologic component. I would be looking at it from the muscle standpoint, and do not need to go out and get a mitochondrial biopsy of your muscle. Okay, can be inferred um, based on symptoms.
Also, I would remind folks about the malabsorption, malnutrition that's happening as long COVID progresses. And if those things aren't addressed in the beginning, a lot of people aren't getting enough proper nutrition to maintain any muscle, and they're, like Dr. Groysman said, deconditioning from not moving. You have to get in a certain amount of protein every day, and a lot of the folks who are athletes, they know this from when they were training, and it's got to be frustrating. What ways do you recommend, Dr. Groysman, for getting protein in when you're feeling pretty crummy?
Well, there's really only one way. Um, it's not so much not being able protein. I think um, but that can be looked at from stool or urine to see the micronutrient, um, the metabolites, basically, to see if you are. But there's really only one way to get protein in, and
So,
there's kind of no
so like
workarounds from that.
protein shakes, I guess, and
Well,
then
what I mean is
yeah,
we're regardless of what you eat, um, it has to enter your gastrointestinal system.
yeah. Some folks have ended up on these different prosthetic feeding tubes, like NJ, NG, and in worst case scenarios, TPN. Um, Fortunately,
Yeah,
have you had
TPN is
any
not
folks that
something I
are on the?
recommend.
Yeah,
I do not recommend TPN for anybody, and it's actually very harmful and it's really only used if your gut is not working. Um, so that's not somewhere I want to go with people with long COVID.
yeah. I've only seen folks who've, their condition has progressed so much and they didn't have a doctor like you around or even knew that you existed. It's just so many years. We're on year 5 now, technically. So it's a lot of folks are happy that you're doing this, Dr. Groysman. Thank you. Thank you.
Sure. Do you want to read our next question? You're not coming through audio wise.
All right. Can you hear me now? Okay. Yeah. I
Yes.
have extreme insomnia. Any guidance? This is from a YouTube user, Pine
I
Needle
see
Tea.
pine needle tea. So
Yeah.
extreme insomnia often comes from the component of dysautonomia, which is an abnormal autonomic nervous system condition. In long COVID, in particular, where the sympathetic nervous system, the fight that normally happens once in a while, is there 24/7 or close to it, and your insomnia is not caused by poor sleep habits or poor sleep environments, such as the temperature, light and sound, um, uh, or having a bed partner that's keeping you awake or something, or like a dog or cat that's keeping you awake. Outside of those, if you look at sympathetic nervous system overdrive, the fight flight response, the goal of this system is to make your body think that it is in mortal danger. So, right? So in that context, it would be very difficult for your brain to really shut down, if that makes sense, even with sedatives, because from your body standpoint, it thinks you're in mortal danger. And while your body is in mortal danger, not only are you not able to really sleep or go into deep sleep, but you're also not digesting, because that's a maintenance function. So any tissues that need to be regenerated, any stem cells that need to replace tissue, they're really not active, because your body's focusing on those two. Even if it's not legitimate, even if it's not real, As far as your body is concerned, it is. So your best bet to beat extreme insomnia is first to determine if you have dysautonomia, and the majority of people with long COVID do. And the second is to treat it. There's several ways to treat it. One is with vagus nerve stimulation. Um, some people do well with nicotine patches, although it can temporarily make insomnia worse. And lastly is the stellate ganglion procedure. Those three would work really well at reversing the dysautonomia and therefore reversing the insomnia for most. I hope your question, Pine.
Okay. The next one is like a couple of comments and then asking if you'd heard of the use of ketone ester supplement for brain fog, and have you seen folks use that, and if yes, has it been helpful? I think it needs to be more specific.
In general, your brain prefers glucose as its main fuel source, and it'll do just about anything to get it. It is glucose intensive, especially your brain. It doesn't seem to like ketones or which come from fat, which comes from breakdown of fat, or protein. It really prefers glucose. So I'm not really sure about the ketone that you're talking about. Things that I have found to be helpful with brain fog. Now, we're assuming we're treating just the symptom of brain fog and not treating the cause of the brain fog, which I believe to be mostly dysautonomia. But if you're just targeting the brain fog, the ones that tend to help would be like the low dose naltrexone, guanfacine, okay, mestinon, which is pyridostigmine, have been helpful, and these have been also tried and true tested with chronic fatigue syndrome. So brain fog has been around long before long COVID, and we've seen it quite a bit from chronic or myalgic encephalomyelitis. If you're just looking for eliminating brain fog, those are the ones to go to. There's some docs have used some of the stimulants that are used for ADHD to help. I personally don't like to do that, but they may be helpful with brain fog. It's usually more than just brain fog, though, right? People have problems with executive functions, concentration, memory issues. So keep in mind that just doing a symptom management would really only treat one or two of those.
And that's kind of why when you go to see Dr. Groysman, he does a very thorough clinical history and works on your, listens to what your symptoms are and what's troubling you, and really pays attention. And it's important the order in which you address things. So you're going to get a whole plan that works with what you can do, that's customized for you. When you see Dr. Groysman and get an appointment, and you do them both telehealth and in person, right? Folks from
Yes.
around the world, and there's over 200 languages and sign language that's available.
240.
240. That
Not
always
in the
blows my
office.
mind.
Not in the office. For online, we can bring on a live translator in one of 240 language and dialects, kind of similar to UN style translation.
That's pretty awesome. That's very cool. We'll have to take us through a demo one of that, you know, make a little video clip for us. Here's Pine Needle Tea had a question before the insomnia. In Ireland, the neurologist they met with said they didn't believe in chronic Lyme and co-infections and offered an occipital nerve block with no ultrasound, just antidepressants. So everywhere you go, they have different interpretations. What do you say to someone like that, Dr. Groysman?
Well, these things really don't have anything to do with each other. Chronic Lyme and co-infections don't really have anything to do with occipital neuralgia per se. I mean, certainly you can get a neuropathy in any nerve in the body. Traditionally, occipital nerve blocks were done blind. I don't do anything blind, but you can do it blind by using anatomical landmarks based on where the occipital, the greater occipital and the lesser run. And pain docs do this. It's basically a fan block. You take the needle and you feel for a spot on your skull, and you go a little bit off to the side, and you do a fan. So you're injecting and redirecting the needle several times, and the local anesthetic and the steroid will eventually get around the occipital nerve. I prefer to do it so I can actually see where the nerve is. Use much less local anesthetic, number one, and put it precisely around the nerve as opposed to just kind of do the shotgun in your skull. But to each their own. Some people do like to do it. It's a lot faster, obviously, to do blind. You kind of can't go too far in the way. So, touching bone, you're basically at the end. At the end of the line.
Gone too far. Gone too far.
Well, no, you haven't gone too far, but you can't go any further.
Right.
It's skull,
Thank
it's bone,
goodness it's
and
there.
the needle is not going to go through the bone. So, but I'm really not sure kind of why the chronic Lyme and the co-infections are being discussed with your neurologist. I'm assuming you would have other symptoms besides occipital neuralgia that that would make you think it's chronic Lyme. Chronic Lyme is a sort of weird condition. It's still not 100% accepted, depending on who you talk to. It's similar to chronic fatigue syndrome. For the longest time, it wasn't really accepted as a real condition, and also fibromyalgia, another one. So depending on who you talk to, you may or may not be believed.
Does that particular area
Amira, are you with us?
Can you hear me? Can you hear me?
Yes.
Okay. Does that area govern the like trigeminal neuralgia? The trigeminal neuralgia, those nerves, are they related to that occipital nerve area?
Not at all.
Okay, so they wouldn't be injecting there to treat that. So I have no clue other than migraines, where they inject all over your head everywhere. The Botox
No, migraines are
injection. That's
different.
totally different.
I mean, we don't really
Okay.
target. We don't really target the occipital nerve with migraines. It's really a muscle injection
Gotcha.
head and into the shoulders. But occipital
Okay.
basically starts out in the neck spine area, the C2 C3 level, and comes off and then travels on the skull around the top of the skull, missing the ear, and goes towards the eyebrow area, so forehead and eyebrow. So it's
Okay.
very different from even the V1 branch.
Okay.
Um,
Just curious. There's one. You want to take this one? I'm not sure what part of it you want to read out loud. Maybe just the last sentence. I don't know what.
I don't know if it's your end, Amira, or mine, but I can barely hear you. So, guys, can you tell me, am I breaking up or is Amira breaking up? It's probably I'm on Wi-Fi when I do
Yes.
these on Sundays, but I don't know.
It
But
it
I
was
can't I
you
can't
were breaking up.
barely hear Amira.
Hmm. Okay. I'm gonna go adjust my volume and make it louder.
No, it's not. It's not a volume thing. It's just you're breaking up every other word or
Yeah.
every word. I only hear like two
Okay.
syllables, but it's
You
not the
were
volume.
breaking up for me. Okay, you broke up for me a couple of times earlier, and I just figured it's the storm comes and goes.
Well,
But you
but
sound good right
if it's
now.
breaking up on your end, it's not possible to know if it's on your end or my end. So that's why I'm asking others and see
Yeah, the
if
audience,
yeah, if
let us
they're
know.
hearing it, if I'm the one or it's on your end. But regardless, this Facebook user is asking about her son. Okay, so it's probably me. It's probably me then. Um,
Mm.
Asking about her son that I've recommended a third SGB injection. Can I touch base on needed and which med I would inject and where I would inject it compared to the first set of injections? Also wanted to discuss the impact positive MTHFR and long COVID. So, in regards to stellate ganglion block, aesthetic will, and I would alter the technique a bit to make sure that there's no possible chance of local aesthetic going near the vagus nerve. Okay, the medication will be the same. No, that wouldn't be different. Um, the second question about MTHFR, um, it's really integrative type uh, providers. MTHFR is very common actually in the general population, being um, either homozygous or having basically a heterozygote that's abnormal, not both. It's possible, obviously, to have um, both genes from mom and dad, to have a homozygous mutation. Um, from the long COVID standpoint, it's really not a huge impact from the MTHFR itself, because even if you were homozygous, that is, both genes were abnormal, the amount of homocysteine level increase is usually not clinically significant on its own. However, when you combine it with long COVID and absorption issues, and specifically if one of the B vitamins or magnesium, so B1, 2, 3, is involved in helping with the methylation, basically the enzyme, the MTHFR gene, which also makes the MTHFR enzyme that activates B9, which is folate, and also B6, by the way. B6 is involved in this process as well. So if you're not absorbing one of these B vitamins well, or if you don't have enough magnesium, you can potentially have a more of an increase in homocysteine levels. That's the first problem. Homocysteine is toxic to our bodies. And normally it won't stay as homocysteine. It'll become something else called methionine. And it's kind of a cycle, passing the methyl component, the methylation part, between the homocysteine and the methionine, which is an amino acid, an essential amino acid, mind you, which means that our bodies can't make it, which means you have to take it in from food or drink. What homocysteine can do is basically cause atherosclerosis or vascular inflammation and endothelial dysfunction. So it can add to the whole clotting thing that we talked about, and you're more likely to form clots from that situation. The second part of this is if you're not passing that methyl group along and it's staying on the, is you're not methylation A. Now, why is that important? Well, we have a lot of extra genes and genetic material in our genome. A lot of it is ancestral, and we don't use it. And the way we don't use it is we turn those genes off. And how do we do that? Well, we methylate them. We methylate the one or two components on the gene, one of the nucleotides, and the gene basically turns off. Now, what's supposed to happen when a cell divides is it's supposed to mirror the methylation of the mother cell, so the daughter, and it's supposed to copy all the methylations that have turned off the genes we don't want to be on in the daughter cell. But what happens if you don't have the methyl component available? Well, you don't methylate, and it's not supposed to be on. And well, you may not think that could be a problem. We got oncogenes in there. We got growth genes in there. And oncogenes basically promote cancer. We got viral genes in there. We got things in there we don't want, but are part of our permanent genome. But our bodies have figured out a way to basically shut them up regardless and not have them active. But that's really the big impact of not having proper methylation. Is you could potentially have issues with cancers. And I don't know if you've seen this, but I have in long COVID. There actually have been quite a bit of new onset of cancers of all types, and I think this is part of it.
So many things going on all at once, all the time.
That answers the question, though. Yeah, I'm trying to reconcile some of these things.
Here, here's one. You shared an informative article yesterday from OU about GI issues from long COVID. I tried telling my doctors for 2 years that I experienced horrific GI issues. It eventually developed into a fear of eating. Have you come across that issue before? It's very difficult to eat if I know my body will reject it. So a lot of chronic nausea issues people are having. So have you come
Sure.
across this issue?
I have come across this many times. It's a very common symptom with long COVID. There are several possible causes. One that hasn't been mentioned a whole lot lately is parosmia or anosmia, and dysgeusia or ageusia, affecting smell and taste, and that obviously can cause aversion to food. If what you're eating smells like a garbage dump or your local dumpster, sort of makes sense for people. And I believe that is due to vagus nerve dysfunction. And that is the normal peristalsis movements in the muscle of everything from your throat down to the rectum is moved along in waves of muscle movement, similar to how a worm or snake move. And if that is not working in the correct manner, in other words, it's not coordinated, or it's not moving at all, that can create a lot of gastrointestinal problems as well. And lastly, we got the gut itself. So there's two things going on here. First is the microbiome. Now, we know COVID affects the microbiome. We know many things affect the microbiome. So when the microbiome changes, it could potentially lead to a breakdown of the zonulin tight junctions in the gut, our body from toxins and bacteria and viruses from the gut into our bloodstream. And the second is the production of acid and mucus can be altered because of the hormonal levels, the neurotransmitter levels, and histamine play into this. So yes, I have seen many different gut-related issues. Some of them are related to the ones that I've mentioned. The typical symptoms I see are nausea, bloating, cramping, abdominal pain, and constipation. And all of these, by the way, can happen from dysautonomia alone or from the microbiome.
All right. Here's another question. All right. Facebook user asks, essentially just wanted to see whether high enough vitamin D in blood test proves you've got enough, or could it be that it's not activated or absorbed correctly? Didn't we do this before?
We did. I don't want to talk
Yeah.
a ton more about vitamin D, but if you're checking in the
Yeah.
blood and it's high in the blood, by definition, it has to be absorbed, because how else is it going to get into your blood? Whether it's coming from your
Right.
skin because you're out in the sun, or whether you're taking in a lot of fish and fish oil product vitamin D in it, the only way it's going to get into your blood is because it's absorbed. So, but it still doesn't tell you if it's activated or not.
Yeah.
All it tells you is the vitamin D. Now, you can test specifically for the activated forms of vitamin, but the standard vitamin D3 test does not look at the act, just looks at what's attached and circulating in the blood.
Okay. question from James. My major issue is my stomach, gallbladder, and kidney EGFR. I can't seem to get any of these under control. Can you speak on the gut tissue and digestive tract as a system? This probably needs a whole seminar on it. We've done that before.
I mean, any of these topics, honestly, I could talk for a week nonstop and still not be able to finish.
Yeah.
Okay, so let's talk about what EGFR is. I don't know if anybody really knows what that is, but we're talking about glomerular filtration rate. Okay, that is basically the kidney's ability to filter what's coming in. Okay, that's essentially what it comes down to. What we're concerned about is when the GFR, that means that the kidney is filtering, which means that the renal insufficiency or renal failure of that sort. The stomach, gallbladder, well, the gallbladder is not really in the stomach, it's under your liver, and it stores bile. So your liver makes bile. That's the excretory function, and it stores it in the gallbladder. Many animals don't have a gallbladder, I found out. But really what it's meant for is to digest fat. Gallbladder bile is meant to break down fat. Okay, I'm not really sure how those would be linked, or but if you're talking about gut issue and digestive tract, I just really went over that from the previous question. So a ton more to add. If we're talking about bile or pancreatic enzymes, those are not typically like they would be endocrine functions. Those are exocrine functions.
And when you see Dr. Groysman, he helps you with, a comprehensive approach so that he's not just addressing one thing, he's addressing everything in a specific order, and that's appropriate for you. So, like they say, if you've seen one long COVID patient, you've seen one long COVID patient. Everybody's different. Your constellation of symptoms are going to be different. And just want to remind folks, when you hear something here, this is like for educational purposes. You can probably be one of the best things you can do is to do a telehealth with Dr. Groysman if you're out of state, or even if you're in state and you can't get a drive in yet, you're not feeling that great. Get a head start on preventing a lot of the cascade of symptoms. It's really important to early interventions in long COVID. Makes all the difference. And
I do agree with Amira that no two long COVID patients are alike. Every single long COVID patient is a snowflake or a fingerprint, and you really do need. Everybody talks about protocols, but protocols is, to me, is like type setup. You fit into this, so here's what you're gonna do. Here's your steps. But long COVID doesn't work like that. There's multiple causes. It's a multi-system disease, and I saw a patient, or not a patient, a person from Facebook comment that one of the treatments didn't work, so therefore long COVID was untreatable. So first, I wanted to mention that there is an end in sight for long COVID. I do think that we're getting very close. I have come up with a lot of different strategies to treat long COVID with addressing causes. The last one that I'm looking at right now is this clot situation and trying to resolve that. you just have to understand that even a simple problem condition such as high blood pressure is not 100% managed or cured. The pathology is rather simple, yet we have so many different medications to manage this one problem. We have beta blockers, we have calcium channel blockers, we have water pills such as hydrochlorothiazide and others. We have ACE inhibitors. We have angiotensin II receptor blockers, right? And there's several others, like hydrazoline directly. So all of them treat high blood pressure. Usually one or two cause problem. It's fairly well defined, and there's so many different treatments for this one problem. Treatment or medication to be applicable to every single person with long COVID when it's a multi-system disease and it is a multi-cause problem. So
Yeah.
it's just unrealistic to expect.
And some things may work in the beginning.
So
There's also some people need different forms of medication, like in cream form or patch form or whatever. It all depends on what your overall health status is. There's like not one thing. Anyone tells you just one thing is gonna fix it, it's gonna take a lot more. And that's why you're really lucky to have, a doctor like Dr. Groysman who looks and researches, and he's always like, did you hear about this? And I'm like, did you see this paper? Did you see this testimony? Did you see, he stays up on it and puts a lot of time to stay not only current on what is out there, but ahead, looking at, you know, down to the molecular level. Sometimes I'm really amazed. It's pretty good. Very few doctors these days are doing that. So, which is what everyone has been experiencing in mainstream healthcare. Hopefully, you guys can learn what you need and get to work with Dr. Groysman. We're always trying to find a way to uh, to be able to provide access to care with doctors like Dr. Groysman. Everyone should have equal access to all the treatments he does and should be able to telehealth and see him. That's what we're working towards, at least on my end, trying to find ways to get access for everybody to
I
doctors like
just want
Dr.
people to be
G.
careful though, because there are some docs that do claim cures, and it's usually the same treatment for everybody, the same therapy or treatment or medication for everybody, and that really reminds me of the bottle of elixir, this magic, also known as snake oil, that treated everything from headaches to gastrointestinal distress to flu to broken bones. I mean, you name it, it fixed it. Um, Long COVID is multi-system. It is multi-cause. And the question asked by this Facebook user, why do some remedies work famously and then suddenly stop? LDN, for example. Well, the reason is because most people are not just having one cause of the long COVID. So it's in flux. The whole system is in flux, which means that one of the causes happens to be more active this time, and 2 weeks from now or 2 months from now, another cause is more active. And therefore, the same treatment that worked 2 weeks ago is no longer working. So, LDN is mostly used for chronic fatigue and brain fog, and it's a symptom-based treatment, which means that if it's caused by help and if it's caused by something else, it wouldn't. So that's really the simple explanation for that.
Someone's asking about nonstop ectopic heartbeats. Is there anything to help for that? That's since they
Well,
Facebook
yes and
user.
no. So you would, I mean, it may seem like a simple question, but it's not. So ectopic heartbeats are extra heartbeats. So it's kind of like the knock of an engine, where the cylinder prematurely detonates the fuel in the cylinder, and basically disrupts the rhythm of the engine and causes a little knock. Well, we feel that knock as palpitations. So there's many different kinds of ectopic beats. The two most common are atrial and ventricular, and they're called atrial. And PVCs are ventricular contractions, premature ventricular contractions. But there are others as well. If there's runs of them, we often worry about arrhythmias. So without knowing if there's actual structural damage to the heart or if there's some kind of recurrent loop causing it, if those are not an issue, it may be from dysautonomia. POTS and dysautonomia both can cause palpitations and ectopic beats. And that has to do with the input coming from the sympathetic and the parasympathetic input into the heart. Yes, there is things you can do to help, but you need to have more information. So, which kind of beat it is, how often it occurs, and if there is any arrhythmia or not. A Holter monitor often helps, which I'm assuming you've had if you know that you have a burden of 11%. But yes, there are ways to treat that. Let's see. We're back to spike.
Can the spike protein cause issues with renin-angiotensin system, potentially leading to dysautonomia?
It absolutely can and does. And that has to do with the ACE2 receptor that we mentioned earlier. The renin-angiotensin system helps manage blood pressure. And it's also involved with some aspects of inflammation. But what did I say happens when a spike protein contacts the ACE? Now, a lot of people think that these spike proteins just attach and kind of float around in the cell, hanging out with the ACE2 receptor, having a grand old time. But that's not what happens. As soon as that spike protein contacts the ACE2 receptor, it gives a signal to the cell to basically engulf it. So the cell membrane pulls it into the cytoplasm of the cell. And the ACE2 receptor does not come back to the cell surface. Okay? So if you remove a sufficient amount of angiotensin to receptors, ACE2 receptors, you will not be able to break down angiotensin, which is one of the transmitters that increases your blood pressure. Okay? And that can obviously lead to blood pressure issues. So one of the potential treatments for that is the nicotine patch, because it helps produce additional ACE2 receptors in your nucleus. It activates the transcription and translation gene to basically make the mRNA for the receptor and have the mRNA converted to the receptor and be displayed in the cell again. And that can help restore part of this problem. So that's one of the ways that I think that nicotine can help with this autonomia aspect of this system. Okay.
Okay, next one is kind of long one. A Facebook user. All right. Says, I don't know how many other people have had this symptom, or if this symptom is definitely from long COVID, or if it's from myalgic encephalomyelitis I developed after COVID. I have terrible pain and burning in the muscles of my legs, which makes it difficult to stand and walk. I recently noticed that rubbing hydrocortisone cream into my muscles help relieve this pain. Any idea what is causing this pain and why the hydrocortisone cream is helping so much?
One
That's a
of the
Facebook
reasons
user.
for myalgia, one of the reasons for myalgia is inflammation, muscle pain. Okay, it's not specific. It doesn't really talk about cause. It just says that's what muscle pain is. One of the reasons for pain in general is inflammation. And we know that long COVID inflammation are good buddies. Um, so inflammation of muscle is not unheard of. However, hydrocortisone cream applied to the skin will have minimal absorption um, into a muscle underneath, even even if you think it's pretty close, there's active tissue in between. So it's unclear why the cream would necessarily be helping unless it's being absorbed um, into the area or closely into the area, and the pain is coming from inflammation.
All right, the next question. All right. Another again, we have
Yeah, I'm not going to address it's been addressed earlier.
yeah,
So
there was another question that Rachel had. Um, I don't know if this is very similar, but how would you recommend to detox chronic inflammation from the brain? A lot of people are developing neuro-COVID symptoms, kind of making symptoms of their ME that they have already been diagnosed with worse, or Parkinson's and made it worse, or having new cases show up. It's definitely been increasing, as well as other uh, neurological and cognitive problems. So people are wondering, how do you address the inflammation going on in the brain? But when you go ahead and treat the body systemically, don't those things help the brain as well?
some things do, some things don't because of barrier. But when you say detoxing anything, whether it's your liver, your kidneys, your body, your brain, what you're saying is you want to remove a toxin from a particular area. And we haven't really proven that it's a toxin-based mechanism in the brain causing the brain fog. Now, it is possible that that recent article on the, I guess, the loosening of the blood-brain barrier can have some component to this because it would make it much easier for normally get in. But I think a lot of this is going to be blood flow related, and what the state of the blood flow that occurs during a fight or flight response is different than normal, and over a chronic or long period really cause the issues with the brain fog and the executive functions and the concentration and memory problems as well. So I'm not completely convinced that it's from toxin based causing these issues. Let's see. Your volume is off again.
Sorry. Chris asks, is there actually an objective measure of the amount of spike protein in the body?
Technically, there is. I don't know yet if it's available to the public, but there was a doctor, I believe in New York, but don't quote me on this, that was using a antigen quantity test for the spike protein um, to evaluate long COVID. But I haven't heard anything recently if the test was validated or not, or if it's available to the public.
I know they can measure the amount of antibodies you have to the spike protein indirectly, I guess. All right.
I don't know if the antibodies really cause spike protein in circulation, so I don't know if you can make that that leap.
Yeah. Here we go. Andrew asks, what role does perimenopause play for women? There must be a connection between estrogen is an anti-inflammatory for the body. We know more middle-aged women suffer from long COVID. So they're generally like 76% of the patients are women, and about 24 to 26% men. I mean, it ranges in that range from what I've seen on the CDC website in terms of numbers when they measure. So, and as
Women in
far as
general tend to be more at risk for long COVID.
yeah.
Are you ready
Our
for
mute.
me to
Okay.
answer the question?
I was just going to say one thing. Women have the capacity to bear children, and we have to have some kind of extra systems in place, immune-wise, to modulate growing a human being, which is technically a foreign object in our body. It's a different human being growing inside our body. So it's a pretty complex system. And knowing that we have to depress our immune system when we're pregnant in order so that we don't completely reject the child. There's like so many complex mechanisms that are happening in the immune system. I guess
We have areas in our
that's it.
body that are immune privileged, what we call immune privileged. In other words, the immune system doesn't really know they're there. The immune cells, the white blood cells don't really go there, and they don't even realize that the system or the organ or things are there. Okay, so I believe that is how it works with pregnancy. But I don't think that's really responsible for why women are more likely to get long COVID, or a higher percentage of women are more likely to get long COVID. There are effects to the menstrual cycle, including menopause, from women who have long COVID. There have been reports of early onset menopause. There have been more reports of menstrual cycle changes. That means that somebody who was normally regular is now irregular. Somebody who had light cycles now is having very heavy bleeding. Or even people who have stopped menstruating at all altogether. for a period of time. Whether it's estrogen or testosterone or any of the other hormone related is still unclear. Um, but yes, both estrogen and testosterone are technically anti-inflammatory in the body. So, but I don't really know yet. Nobody does, I don't think, about hormones and long COVID changes in the menstrual cycle or menopause. Um, we've run tests, and there haven't been a lot of changes in these hormones. I'm not saying they're not involved, but it's still unclear to me how they are.
Just
Okay, looks
related
like
to that,
Mina commented on.
posted. Go ahead.
I'm not sure where
Nina
that one
commented,
was.
there was a study just last
Yeah,
week on low testosterone, harder long COVID symptoms.
sure. I haven't seen that one yet, but I'll look for it. But like I said, even if they are involved, I hadn't seen any changes in my population. But like I said, doesn't mean that it's not involved.
Okay. This one was more of a pretty long comment here, and then this
Sure,
person is
Nina, you can post the
wondering,
link. That's fine.
yeah. Facebook user, let's see, says, whenever I walk more than 300 steps, my whole body shuts down and I'm completely exhausted. I average about 1,000 steps a day. When I crash or have an episode, my head gets really heavy, my heart feels really strange, funny, and it hurts sometimes, squeezing pain. I don't get tachycardia. I'm completely confused, and I have to just lay down for hours till I snap out of it. I feel like I have something stuck in my chest on my left side close to my heart. So I pace throughout the day and move as much as I can. What could be causing this issue? I can only be on my feet for 6 minutes before this issue happens. I don't have POTS or orthostatic is it orthostatic hypotension or hypertension? Oh, OH, says OH.
Orthostatic hypotension.
Hypertension. Okay.
It's a more severe form of POTS.
Okay. Thank you. So what could be causing this issue, Dr. G?
So this type of symptomology is also related to post-exertional malaise and is related to chronic fatigue syndrome. It's one of the cardinal findings that we see with chronic fatigue syndrome. When you say you don't have POTS or orthostatic hypotension, I'm assuming you've been tested at least with tilt table, and not just saying that you don't have it. Um, you are pacing, that's good, but are you using a regimented pacing program, or are you basically pacing and doing as much as you can until you can't? In which case, that's not really pacing. That's kind of what's leading to the crashes, and the crash is what's causing you to shut down and be completely exhausted. Now, I'm not sure who you are, but I do have a pacing protocol on the website. If you go on covidinstitute.org under treatments, and it is closer to the bottom under that tab. Let me see here. It is titled PEM and about like doing one extra or two extra steps a day. That you have to be in order to get your body used to um, more than what you're doing. Can you guys hear me okay? Because Amira froze again.
Uh, I'm still here.
Can you guys hear me? I didn't know if you heard what I said before or not. Okay, good.
Let's see. They're saying yes.
Good. I just want to make sure because I don't get that feedback, unfortunately. And when Amira freezes, I always worry that it's me that froze, not her. And it may be, but I just don't know which end is having the problem, and therefore I don't know if my message is getting through. But anyway, as I said, on covidinstitute.org, if you go into treatment and you go into PEM pacing, it will that will show how slowly you need to actually increase the pacing. Number two, I believe that a lot of this is mitochondrial. Okay, and what I would do is I would supplement for mitochondrial function. Okay, and I would start with regular supplements. Let me put it in the comments because I don't know. Some people are saying, I guess, that it is not in treatments tab on DM and paste. So yeah. So I'll post it here so you guys can read it. The second part that I think is involved in this is mitochondrial dysfunction. Let me see. Mitochondrial dysfunction. So the mitochondrial dysfunction is the second part of this. And I think it's the primary reason why people have the post-exertional malaise and the crashes that you get, because there's no reserve built in. And you have very limited ability to do aerobic metabolism, which means, it may be a couple of steps before you crash. So there are supplements you can take for this. And if the supplements aren't cutting it, then there's prescription medications that you can take for this that have been successful at reversing the mitochondrial dysfunction. I hope that helps. Sarah, if you do, let me know.
Oh, here. It's more of a comment. Facebook user says, my daughter developed breast cancer at age 29 with no genetic cancer abnormalities, and my 35-year-old cousin just developed lymphoma. I think you're on the right track about a link between cancer and COVID. I think it's very important not to miss those regular pap smears with your doctor and regular checkups, because I don't know if it was the lack of access to care during the pandemic, but since the pandemic started, there's been an increase in the number of cancers across the board, all kinds of cancers. I can't tell you how many folks I've heard from that said, oh, I talked to you in such and such time, and I reach out to follow up on them, and they've got kidney cancer, other cancers, and they were very healthy before getting COVID. So I think it's important to get your regular checkups and not to miss any monitoring with your provider. What are your thoughts on that, Dr. G? Oh,
I mean, you can screen for cancers, but I mean, there's only so much you can do. You know, how often would you screen? Some of the, um,
yeah.
for instance, I look at thyroid nodules. If I see them, I'll tell them. Um, and I've diagnosed several people already. Unfortunately, it's not something I wanted to do, but probably saved their life. Caught it early. Meg is asking about if I'm going to list the supplements for the mitochondrial dysfunction. You're not going to take all 20, and it's not there's not a Russian roulette for deciding which ones to take. That's kind of what I do. Is based on what's going on, I will select several based on your symptoms, based on what other medications you're taking, other medical problems that you have. I would recommend several of those, and then I would prescribe if needed or recommend for a local doctor um, if you're, let's say, out of the country, what I think should be prescribed. So just listing them is not going to be all that helpful because there's too many to choose from that could potentially help, but you really need some expertise in deciding which ones you want to take. Okay. I could move these sessions to the week when I'm at the office and I have a landline there. We have a very fast fiber optic system. I wouldn't expect any problems, but I'd office um, just to do these on Sundays. So one to move these sessions to the weekday instead of the weekend. So I want to hear some feedback. If that's what you guys want, I can certainly try to make that happen.
If you all want to reach
Using
out,
more now,
oh,
live or not,
you are. Yeah, yes.
but I guess I'll
A lot of people like Sunday.
wrap it up. We're at roughly at 1 hour and 45 minutes.
I want,
Since there's no new through, yeah, I see your Zena, but
oh,
I mean, for basically look at the thyroid, the free T3, free T4, um, and TSH. There's a few others you can look at, but at least they'll tell you if it's a hot nodule or not. In other words, if it's producing hormones or not, the thyroid hormone or not. Some people need to have that biopsied. If the nodule looks suspicious or if it's a hot nodule, some ENT doctors and even general surgeons may want to biopsy it, maybe even do a needle biopsy and see if those cells are cancerous or not. So, Amira, do you have anything else to add? Because otherwise, I'm going to wind this up. us?
Just want to remind folks, you can get more information at covidinstitute.org, and for making an appointment, just reach out. Any questions you have, folks are very happy to answer them. And if you, it doesn't matter where you are in the world, as long as you have an internet connection, you can get a telehealth appointment booked online, or you can call in and book an appointment. We're working on the getting your appointment. It's coming in the future, where you can book your appointment through our website, and you can visit longcovidassociation.com or assoc.org if you need to reach me and ask any questions, how you can advocate and help and support our research efforts. And I want to thank everyone for taking time on their Sunday to be with us. And here's a question that came out: how do you restore endothelial function? That is a whole seminar.
I think right. I think I'm going to be done today for answering questions
Okay.
at this
Yeah,
point
I'll
because
say that's
we've
for
come to the
next
end.
time.
That's for next time. Just come back next time and ask your question.
Yeah,
That'll be in 2 weeks at 3 p.m. on Sunday,
yeah.
unless somebody asks for
3
me to
p.m. Central
change.
Standard,
Um,
4 p.m. Eastern, and
yeah. So we
the
shift
telehealth
every 2 weeks.
appointment. Someone has a quick question on the telehealth appointment. It's a telehealth appointment with Dr. Groysman, and he has that on his website. Um, if you have any difficulties, you can reach out to me or call his main number, and we'll answer your
If you go on
questions on how to get it done.
covidinstitute.org and go to contact us, it has all instructions on how to set up an appointment or request an appointment.
Yeah.
So that's probably the easiest. And that allows for people internationally to be able to do that as well. And
Yeah.
like Amira said earlier, we have a setup that allows for live translator, not AI, not a computer. This is a live person
Yeah.
that would come on for one of 240 different languages or dialects, including American Sign Language. Now, I don't know if sign language works the same in other languages. Well, in other languages, but I know Americans through telemedicine or through the portal.
And
All right,
folks who are calling from the U.S. or folks who are calling from the
we
U.S. or
got Amira.
Canada use one phone number. I was just telling them there's a Signal app for those that are
I don't think my
overseas that
connection
you
is
can call.
good because I keep cutting out. So
Yeah, I was just trying to tell them, for those who can hear me,
I'm
if you're
breaking up. So
overseas,
I'm gonna go ahead and
yeah, uh, if you are overseas, there's a
stream
special
here
phone number.
because my connection is not doing well and um
Uh, one- okay,
okay.
if you are overseas, I'm trying to message at the same time to let them know I wanted to get this info to you. If you're overseas, there's one phone number you can use with the app
I
called
can't
Signal.
copy that.
Oh,
Yeah, I can't
okay.
copy the posted.
Yeah.
So
Anyway, there's a separate phone number for the
maybe
US and Canada.
maybe it's somehow to Amira or um, to me, but I can't copy him off here. Sorry. Contact me on the Facebook group or private messenger. Just to remind you or treat you to Facebook or private messenger that requires a consult.
Yeah.
And for many different. See you in 2 weeks. That would be
March 31st.
Sunday 4th. No, Sunday the 31st. March 31st at 3 p.m.